Committee, Cook County Health and Hospital System. I'd like to call the meeting to order and ask the Secretary to call the roll, please.
Present.
Serving as a substitute member, Director Ryder.
Present. Here.
Acting Chair Story.
Present.
Director Webster Cross is absent, and Chair Curry is absent. You have a quorum.
Thank you, Madam Secretary. Do we have any public speakers who've either in person or virtual this morning?
We did not receive any registrations, nor did we receive any written testimony.
Thank you, ma'am. We'll then proceed with the agenda, the report on health plan services. Our Chief Administrative Officer, Mr. Aaron Galena, I would ask you to proceed with your report, please.
Thank you, Chair. We'll start with the first slide, which just lays out the agenda for today. We'll cover our usual key metrics and objectives with results. So we'll cover metrics around membership as well as our recent CAP scores, which are member experience scores that we evaluate each year. We'll also do a review of certain strategic initiatives, including redetermination, and then we'll close with a update around marketing. On the next slide, I wanted to start off just by recognizing our county care team on in a recent achievement award they received from the National Association of Counties for our Brighter Beginnings program. This is a program that is a maternal child focused program and helps to engage members and provides them additional benefits. And our team was recently recognized by NACO, and I wanted to thank our team for all the work that they've done putting together that program.
Congratulations.
Thank you. So starting with our metrics, current membership is right around 457,000. We'll discuss redetermination in a bit more in depth here in a minute, but this is the first, July was supposed to be the first month we were expecting to see impacts on membership because of redetermination. However, the state provided a 30-day grace period, so we're now not going to see those impacts until August. So membership was relatively flat month over month, which is good news. And then members that are impaneled to our Cook County Health Clinics also stayed relatively stable, right around 42,000. On the next slide, in terms of market share data, we ticked up from 32.3% to 32.4%. The rest of the market stayed relatively steady. We have seen Blue Cross also increase just slightly in market share, but for the most part, the market stayed relatively stable for well over a year now.
If we moved up, who moved down? Who lost?
We increased market share from 32.3 to 32.4. I believe Aetna Illini Care ticked down just slightly in market share. Comparison to the overall Cook County Medicaid market, you can see our membership increases have tracked really closely to the overall Medicaid market, which is relatively as you would expect, given that the overall market share data by plan has stayed pretty similar as well. The next slide shows our membership compared to budget. The orange bars here are actuals. The blue bar is our budget. Of course, we assumed redetermination would be starting earlier this year. As I mentioned, now we'll see those impacts beginning in August. So our actual membership continues to exceed by a very substantial amount our initial budget projections. And again, we'll see the initial impacts of redetermination in August, and that will flow through the course of next year. And as we head into our budget presentations in the next couple of months, we'll be sharing our projections on what the next 16 months or so through the next fiscal year will look like. The next slide shows our operations metrics. So our call center and encounter acceptance rates have stayed within our expected SLAs, pretty consistent performance here over the past 3 months. Overall, this is good news. We've been monitoring this particularly closely, given we're seeing an increase in call volume with the start of the redetermination process. So, this is something we'll keep a close eye on and want to make sure that we're very timely in answering calls and being able to assist members as they go through that process.
Yeah, I see our hold time is above the state limit. I mean, we're talking about 2 minutes and 30 seconds as opposed to a minute.
Yes, that's correct. One thing we've seen is the length of the calls have increased recently, likely because we're having longer conversations with members because, again, because of redetermination and some of the detail associated with that. So that is the one area that we're working with. Part of that's, I think, training with our call center staff to ensuring that they are able to more efficiently go through those calls and get the issues resolved. But generally, the abandonment rate hasn't been significantly impacted because of those hold times, which is the kind of correlation that we look at in those two metrics.
Aaron, this has nothing to do with any staffing issues in call center, is it?
No, we are fully staffed.
Okay.
And does this include redetermination, questions about redetermination?
Yes, it does. Any other questions on call center I can answer?
No, thank you.
Moving to the next slide, the current versus prior year inpatient utilization. The orange bars here are the prior period, the blue bars are current actuals, and then the light blue shading is projected experience as we wait on the claims run out and we use authorization data and some actuarial modeling to show the projections here. Overall, we've seen, continue to see year-over-year decreases in the inpatient utilization, which is good news. One comment I will make is that we have heard from some health plans, both locally and nationally, that they're watching for some trends they're seeing where they're seeing an uptick in utilization, not necessarily inpatient, but on the outpatient and professional side, as individuals are heading towards redetermination. Some of them are concerned about losing coverage and seeking out services. So that's something that we're going to be keeping a close eye on. We're still pretty early to be able to see that data, but over the next couple months, we should be able to see if we're also experiencing that trend within county care.
So you're saying that we're seeing an increase in outpatient visits?
We haven't seen that yet in our data, but we are hearing that other plans are seeing that nationally. And so that's something we're continuing to monitor on our side. The next slide shows our COVID vaccination rates. Again, this data has been relatively stable for the past few months. We're continuing to see a few thousand individuals each month receive additional vaccinations, which is tracking with about the volume of new members coming into the plan. So roughly the overall percentages have stayed relatively steady. And we provide a breakdown here by age category and by the booster doses, so you can see the information broken down across each of those categories. The next slide shows our.
I know we ask this question probably every month about the encounters with the providers and patients in asking that question about vaccination funding over and over again, right? It's just part of their protocol, and we still have such resistance or hesitation.
Yeah, we still have seen some of that hesitation. I think particularly in terms of the latest boosters, we see that more than on the initial series. And I'll also let Dr. Collins add any additional comments that she may have.
And I think as more boosters come out, we're seeing COVID fatigue. We've had people say, you know what, I'm not getting vaccinated anymore. Like, when will it ever stop? And, and I've started to tell people it's probably going to be like flu. We're going to get an annual vaccine against COVID. So the fall will hopefully help us sort of sort out since the PHE has been lifted. But yeah, some folks have just, I'm done with COVID vaccinations, unfortunately.
So there should be a campaign, I guess, around the next booster that comes up.
Absolutely.
Which is really interesting because it'll happen during the flu season when there'll be a campaign for people to get flu shots. And what people may not remember is there are a lot of people that don't get flu shots either. And the deaths from flu are unacceptable as well.
And the hope is that the combo vaccine will be ready, so that becomes one conversation as opposed to two. But yep, that's probably when the next height of conversation resumes, it's probably early September.
And why do we have so many flu outbreaks, and why is the flu still around? Because people never got vaccinated at the rate that they could have to choke it out.
History repeating itself.
Well, and like, well, it's just the flu. It's like, guess what? Nobody likes to really be sick, do we?
And if you look at the data, actually, the fall of 20, we probably have the lowest flu rates that we've ever had because we were sheltering in place.
And
we were washing our hands, we were wearing our masks. And so we know it works. But yet people just, once it's over, they go back to old behaviors.
I am hoping that after what we've experienced, that people are continuing to at least wash their hands. That was the most disturbing mitigation thing, that we had to make sure that people were washing their hands and washing them for the appropriate amount of time.
Is the new RSV vaccine coming out this fall?
So RSV, I haven't heard of a new vaccine for RSV that's coming out, but there's supposed to be a combo flu COVID coming out for the fall.
Or flu and COVID.
Correct. Yep.
One or the other.
Any other questions on vaccination we can answer? With that, we'll move to our next slide on claims payments. Generally speaking, we're within the range that we're targeting here. We'd like to be a little bit lower in the 30-day range. You can see we're right between 30 and 60. Partially, this is just due to timing of the data versus when some of the payments went out after this latest report. So we're a little closer to the 30-day mark now. And generally, we've continued to see consistent payments from the state that have been timely, which is also helping us ensure that our payments going out to providers are also relatively consistent in timing. If you look on the next slide, you see this broken down by aging categories, so 30, 60, and 90 days, and you can see that most of the dollars are within that 0 to 30-day category. There's about 30 million in the 30 to 60-day category, and that's really the category that we're focused on trying to drive down to mostly eliminate that, so we're really just at the 30-day mark. The next section moves on into our what's called our CAPS results, which is our Consumer Assessment of Healthcare Providers and Systems survey. This is a standard national survey that's done with health plans. It's conducted on an annual basis, and the purpose of these are to gather feedback about members' experiences with their health plan and healthcare providers. The survey is sent out to members. It is anonymous, voluntary, and has to be administered to a statistically significant member. There is an independent assessor who sends out and performs the surveys on health plans' behalf. So the categories you see in the blue boxes here are the categories that we receive ratings back on, and we'll show you some of the initial results that we just recently received. We'll also do likely a deeper dive into some of these categories in the future with some of the action plans that we'll have as we've had a chance to digest these further and do some analysis on some of the trends we're seeing. But just sharing some of the initial results on the next slide. It's broken down between an adult survey and a child survey. So on the adult survey, we saw increases and significant increases in rating of health plan, which is the overall rating and one that we in particular look at, rating of healthcare and rating of personal doctor. We also saw increases in getting care quickly and how well doctors communicate. So overall, I think we were pleased with the results we've seen here. We had a couple categories where we saw some relatively minor decreases in as well. So we'll be, again, monitoring those and coming back with some action plans around how we're going to implement some changes there. Generally, though, I think we, again, are pleased with the results. A lot of the categories that we've seen increase are categories that we were targeting over the past year with some of our initiatives. So we're seeing some of the validation of that through these surveys, which is good news. I think access continues to really be the thing that we hear from members, especially specialty access, which is, I think, the biggest challenge that we have in terms of being able to provide a better member experience, and an area that we continue to be really focused on. We added quite a bit in terms of urgent care to our network this year. We're also focusing on adding telehealth to try to improve some of the ability for individuals to have better and quicker, more timely access. And so some of those efforts, again, I think we've seen flow through these results, but particularly specialty access continues to be an area that we have opportunity.
Yeah, looking at this, we appear to be at or above the 70th percentile and everything. And so I would assume because we're above average, that means it's good. But I mean, do we expect to be between, what is our expectation, between 80 and 90% or?
Higher.
Higher. And is there data on some of the other plans, and do we know how we compare to them? Because this is specific to.
Yep, this is specific to us. They break down all of the health plans nationwide, and so we can sort of see where we fit. I can't speak to that now. I want to say we're like dead smack in the middle, but yes, they do sort of list out nationally when they're done with the complete analysis of where everybody.
It'd be interesting to look at how we compare in terms of these measures with some other people locally.
Yeah, and some of the information we're still waiting on is we'll get a breakdown that'll include some of those benchmarks, as well as breakdowns by provider groups that we have. So we'll also be able to see, for example, how different providers in our network, when we look at this data, how they performed as well. And so both of those components will be really helpful, again, as we develop our plans for the next year on how we can improve these scores.
So how long will it be, Aaron, before you all get that comprehensive report of the other plans, locally, national? 2 months, 3 months, end of the calendar year?
Dr. Collins, if I am correct, we receive those usually in August to September.
That's what I say, yeah, we should have them by the end of September.
So would that cycle into our next meeting?
Yeah, so our next meeting is in October, so we should be able to bring that data back to the October meeting.
Well, we'll look forward to seeing it in October then.
Great.
I have one quick question, Aaron. When this survey is sent out to consumers, does it define or expound on the metrics? So if I'm taking a survey and it says rating of healthcare, do you sort of tell me what that means?
Yeah, there's not a ton of additional detail that's provided on the survey to members. And one of the things that we've seen is sometimes there's an expectation gap. So when you look at, for example, getting needed care quickly, what exactly does that mean? Like, what's a reasonable expectation for an appointment, for example? And so part of what we've also started doing over the past year is trying to provide some education and reasonable expectations around some of these different areas, so that there's at least some context as a member goes in and tries, answer some of these survey questions. But the survey itself, again, which is standardized, provided by a third-party auditor type structure, doesn't, the questions are standard and there's not much additional definitional information that's provided on the surveys.
One of the things I would assume is that they survey a percentage of our members, and so they send out a certain number. And do we know what the rate of return is and what is based on? Because it'd be interesting to know, if they send out 1,000 surveys, do they expect to get back a minimum of 500 surveys to actually before they start? And so this would be a representative sample of, I assume,
Correct.
our patient population.
Yeah, I forget the numbers that we sent out for this year, but our response rate for this year was significantly better than last year, although of course not where you want it. I think the national average when you do these, say 25% is about on average what you get in terms of response to these. we were at low 30s. So again, and we opened our sample. We actually sent out more than we sent out last year in an attempt to try to get a better response. So we got a little push on that. We also went from just sending it out to mail to also making some telephonic calls and emails to members to try to get that push, to get people to respond back to us.
Okay, so we get back 30%?
About 30% responses.
So whatever data we're looking at is 30% of our entire patient population.
And you have to remember, the sample size is much smaller than our entire population. We don't
That-
send it to the
that
entire
I know.
population. Of that we sent out, a 30% response.
Yeah, and the reason I'm making that point is that we have to be careful about how we interpret the data, regardless of what the definitions are.
That's what I was getting ready to say. Yep, it's a very small sample. And unfortunately, you're graded on it significantly, although it's a very small sample.
Yeah, and to that point, I mean, it ends up being a few thousand surveys that's underlying this data. The other thing that we've begun doing with the help of Alex and her team is we do pulse surveys now monthly, where we try to incorporate some of this data in our own surveys that we're doing throughout the year, so that we can monitor not just on an annual basis, but differences that we're seeing in some of these results throughout the year, and as we implement new initiatives, how that may or may not be changing some of the scores throughout the year.
Aaron, does the independent survey of actuaries, they ask you all, Dr. Collins, for y'all feedback on these survey instruments?
Actually, yes.
At the end
Most
of
of
the
them
year.
are standard, but we do have an opportunity to add supplemental questions. Like last year, because specialists continues to come up, we sort of wanted to dig a little deeper in that, and so we could ask some questions around that. But they only give you a very small number that you can add on. But you do have some input in terms of additional questions you may want to ask.
And one of the reasons I ask the question is because there are limits to the data, and sometimes when you make a report, you indicate what the limits of the data are, so people don't go off making assertions that are not true or accurate relative to the data that was presented.
Agreed.
I have a question. When you do the telephonic surveys, are they the same questions or is it abbreviated?
It's the same question.
Same question. Have you guys considered doing it biannually?
So the formal survey itself is an annual process. What we have done is we've developed a separate mechanism for us to survey members on a monthly basis, and we've started, and we'll do that on different topics, but we've started including a core set of these questions in those monthly surveys so we can get some of that feedback more in real time.
And we also have some meetings on a quarterly cadence with members where we try to tie some of these in also. So they're continued to get hit all through the year on the ask of the question, and really, not so much what it means, but them to start thinking about, oh, when I answered this last year, it probably was something different. So we can't coach them, but really just putting them in front of it to always be thinking about, things that, for instance, rating of your health plan. What do you think we could be doing better? And so we can talk through with them what we're doing in an attempt to try to move the needle on that response in terms of ratings.
Okay, you say you do some education. Do you guys send out letters to let the members know that they may be polled and kind of give an explanation of the question so that they can better understand them?
We can't give an explanation of the questions is against the law. So we're limited in terms of what we can say, when we can say it, and how often we can say it, and when we can say it related to when the survey comes out. So there's some limitations around that, so we have to be really careful.
Thank you.
For the record, Madam Secretary, Director Cross is present. Thank you. Can I, excuse me, Aaron, in addition, Dr. Collins, are there other surveys that we here at Cook County utilize other survey instruments? The focus groups, for example, throughout the year that sort of give us a comparison relative to this instrument and other maybe internal instruments that you all utilize?
Yep, we do focus groups throughout the year on various topics. I know you said not surveys, but we also have a segment of ensuring in terms of, response to our care managers and members. We have a care management survey, and our member meetings are an opportunity also for us to pose questions to the group. And really, anytime we have, interaction or conversations, take, for instance, our READY events, any opportunity we have to, ask questions of our members, we do. We're actually getting ready to start, a campaign around, changes we're making to our cultural humility player for the year, and meeting directly with members to try to get their input on those also. So those are just a few examples that readily come to mind, that we do with members.
Thank you.
Yeah, it's not a question, just an observation or maybe a statement. My understanding is a lot of times when you're doing surveys like this, you ask open-ended questions, but those open-ended questions can be coded, and therefore they can be actually looked at as actual data points once they're coded.
Actually, these are probably the exact opposite. They're very specific, closed-ended questions,
Okay.
where you rate. So it really is, not the same in terms of being able to pull data from some of those.
So it's clear that it's
Open-ended,
closed-ended
yes.
questions.
It's sort of a 1 through 5, yes or no.
Yeah, and, to that point, certainly some of the internal, feedback metrics that we try to get from members, we do ask some of the more open-ended questions to try to get some more, detail or, glean some additional information. The formal surveyor here, it's much more defined on how they ask the questions.
Thank you.
Slide 17 shows the child survey results. Again, this is split between adult and children. So we saw increases in rating of health plan, rating of personal doctor, rating of specialist, coordination of care, how well doctors communicate in getting care quickly. And then, again, I think there's some areas that we saw some decreases and some opportunities for improvement that we'll bring back for action plans. So getting needed care and customer service were two that I would call out here. And again, those will be topics that we bring back for some additional conversation around. Moving on to our next section, I wanted to provide an update on our NCQA reaccreditation. County Care is accredited by the National Committee of Quality Assurance. This is the main regulatory body or accreditation body for health plans. It's also a requirement that to have a contract with the Department of Health Care and Family Services for Medicaid, that you are accredited by the National Committee of Quality Assurance. We are in currently the window of going through our reaccreditation, so it's done every 3 years. We were originally accredited in 2017 or reaccredited in 2020, and so are going through the reaccreditation process currently. We've completed, I would say, the bulk of a lot of the work around this in terms of submitting evidence, our processes, all the documentation that has to be submitted. We have a 2-day on-site that's scheduled with the NCQA auditor staff on Monday and Tuesday of next week. So we have been doing a lot of work around this, and then the other component that goes into the NCQA reaccreditation is quality scores. And so there's really two main components. The first is your processes and your documentation and evidence. And then the second component is overall performance on quality scores. So the next slide just shows some of the timeline of how this happens and where we're at in that process. So as I mentioned, we've completed a lot of the submissions. HEDIS and some of the CAPS results we just mentioned to go into your overall rating. In early August, we will expect to get information back on our accreditation status, and then early September, we get the final ratings that are released, and September, they're released publicly. So I think overall, we feel very good about where we're at in the process, and I think fully expect to be reaccredited, but we'll provide more information once we get the final results back.
Yeah, I have a question. It seems early September is when the final ratings, come to us. And if we have a concern about an area where we might be rated lower than we expect it to be, can we argue that? We have between,
You do that on the box prior to that. So the early August,
okay,
the projected ratings are released, you have time to look at it, confirm, sort of audit yourself, and reply prior to those postings early September.
and will they release them whether you agree or not? After the-
Probably. If only it was that easy.
Moving on to slide 21, our next section is around redetermination. So we originally anticipated for this meeting that we'd be doing a pretty deep dive into the first set of members that we saw potentially lose coverage, but with the 30-day grace period that the state provided, we're still not quite there yet. We'll get over the next couple of weeks for August that list of members that are losing coverage, and we'll go through a number of analysis as soon as we receive that to try to understand better where we're seeing trends in that. But certainly I wanted to just re-highlight, where we're at in the process of redetermination right now, a lot of the work that's happening, and then also share a little bit about some of the analysis and review that we'll do once we have some of that initial data. So again, our redetermination strategy is really focused on trying to get to every touch point that we have with a member. The initial letters went out to individuals in May. There's basically a 45-day window, which has now been extended 30 days. But basically a 45-day window once a member receives a letter that they have to fill out the information and submit it back. Individuals cannot, really take much action before that window, so they have to receive that letter and then fill out the information and submit it back with that letter. The only things members can really do before that window is to provide, updated information to the state in terms of their address or phone numbers to make sure that that letter goes to the right place, but there's not much information that can be provided to actually go through the redetermination process before that letter goes out. So we really use a multi-pronged strategy where we work with our providers, we work with our care management teams, our call center staff. We have outreach campaigns that has outbound calling, texting. We have a large number of community outreach events that have been also ramping up during this time. So there's a lot of activity going on right now, as I mentioned, and we'll continue to update you as we go through this. On the next slide.
Aaron, can I just ask, in your opinion, Dr. Collins, why do you all think the delay occurred here in Illinois when other states have been more aggressive in decoupling?
This is just Yvonne Collins.
Yes, I'm just curious about it.
I think we probably weren't totally prepared for the volume of folks that were going to come through. I think we had a whole bunch going on with the migrants, and then we had redetermination sort of all going on at the same time, and it overwhelmed the system.
Okay, so the state was trying to catch their breath.
Yeah.
Yeah, I think overall I would agree that there's just a lot of it's the sheer volume and ensuring, I think the state wanted to ensure that they were as prepared as possible to handle that volume. And then, I think there was also a very real concern about, ensuring no one potentially loses coverage that could have kept it. And I think the state was trying to exercise to the best of their ability any authority they had to help individuals maintain their coverage.
Yeah, looking at the fact that in August of 2023, the first terminations will occur, probably by September we'll have some idea of how much of a hit we've gotten and maybe how much of a hit we can expect moving forward.
Yeah, so by our October Managed Care Committee meeting, we'll have our August and September data. So we'll have 2 months worth, which I think will be really helpful in understanding, there's some really big assumptions right now that we have around how many individuals were, we have some sense of how many individuals are, potentially submitting information back, but what we don't know right now is how many of those are still qualified for coverage. And so that's a really key assumption point that we'll start to get a couple months worth of data on. And then, we'll also have a much better sense of how many have lost coverage just because they haven't submitted any information back.
And does the state have any idea, or have they made any projections about how many people will lose coverage, they feel or believe?
Yeah, there's a number of estimates out there. I think generally they range in the 20% range, and that's not just the state or HFS, but I think there's been a number of estimates done by the federal government, by associations, et cetera, and I think those have generally ranged between 15 to 20%.
Yeah, and if it's higher, if it's like 30 or 40%, perhaps the state will say pause things and take a look and see what they're doing, or if they're doing something that's really not working, because that could be very critical moving forward.
And I'll also make a comment as we head into budget season, but I think, right now we're obviously having to build a budget without a ton of that initial information. So a lot of the assumptions that you'll see as we present the budget over the next couple months is, using roughly those national estimates as, our range. I think we've done modeling between 15 to 20%. So that'll be something as we head into budget season that we'll be looking at really closely.
Thank you.
Slide 23 on the redetermination strategy. This just highlights the blue bars here are a number of individuals that are due for redetermination. The orange is what's called estimated for Form B. Form B being the form that individuals that have to fill out the form. That's the form that they have to go through. What's called Form A members are members that basically automatically requalify, so they do not have to submit any paperwork. So you can see here just some context around, we have a total number of members going through redetermination. What number of those were either we know information now from the state, how many automatically requalified, or we're projecting out how many are going to automatically requalify and what number of individuals will have to go through the Form B process. So that's, somewhere in the 50-ish to 60-ish% range right now that we're expecting will have to go through that, the process of filling out, and then, in the 40% range are individuals that are automatically requalifying. And then on the box on the right-hand side and the box below, we just provided some highlights of the initial batch of members that we have outreach to, and just providing some context of all the different work that's happening in terms of raw numbers of postcards that have gone out, calls, how many calls we've gotten back into our hotline, so that you can see some of the initial results. And that's just from the first month, from the members that received their letters in May.
This might be a rather simplistic question, but I'm gonna ask anyway. How does the state determine who those individuals are that were at risk? Is when they initially signed up and worked back to the one individuals who have the lowest amount of coverage?
Your question is when, how does the state determine when an individual goes through the redetermination?
Yes.
Yeah, it's based on their original date that they were approved for Medicaid.
Is that like, so is that a like 3-year, 2-year?
It's typically an annual, so each year they have to go through that based on the date that they qualified and then recertified. So it's a 12-month basically eligibility that's put to the system. And then the state's gone through a process where they've rolled forward those dates over the pandemic, so that not everyone's going through redetermination right away, but that it's phased out over 12 months. But it's based on the original date that they qualified for Medicaid.
So every year whether we were at the public health emergency and ended or not, people go through an annual.
Correct.
But what's nice about this session is that they've identified a way that if they can find information already on your income, you don't have to redetermine, which is instead of that, whole 20,000 in June having to go through redetermination. If you have SNAP, if you have WIC, if you have other mechanisms for the state to identify you, then you don't have to go through that process. They automatically redetermine you. But
Okay,
when
so
you
there's-
don't have any of those things, is when you have to go through that process.
Okay, so in a simplistic fashion, then they scrub the accounts of all those individuals
Mm-hmm.
who are up for redetermination on an annual basis anyway. And if the state has that information, as you said, Dr. Collins, you get the pass.
Right.
Okay.
What percentage of our members get the pass?
It's almost half. If you look at the bar right there, so if you look at June, it was about 24,000, and about 11,000 needed to redetermine.
Yeah, it ranges between 40 and I think the highest we've ever seen is 60% automatically requalified. So slides 25, 26, and 27 just walk through, and I won't read through each of these, but just give a little more detail around sort of each of the efforts that we have from the application assistance that we offer here through the health system and financial counselors to community events that we do. Slide 26 shows additional work efforts that we have with our care managers, which of course have a lot of established relationship with members, and we have flags for them so that they know when they're talking with the member if they're up for redetermination. Same thing for our call center, same thing for our PBM. We've also developed external partnerships. So Chicago Public Schools is an example of that. And again, are continuing to try to build out those with our community outreach events and the community teams that we have, and finding additional ways to work with community organizations. We also have a lot of work that's focused on our providers, especially our primary care providers, so that the provider is aware when a member walks into their office for their annual visit that they're up for redetermination, and can provide some of that information to them, and really just ensure that they have the awareness that they're up and that they need to fill out the paperwork and where they can go to find that, and where they can get help. And then the last slide is slide 28, and just wanted to provide an overall timeline on the different work that's underway. A lot of that, again, launched as we headed into May and got the first batch of letters, and then we're in a little bit more of ongoing work efforts where a lot of those initiatives, we've now gone through for the first month, and then each successive month we'll launch just a new campaign for the next group of members. And then as we get that data back that I mentioned, we'll be able to see, what has potentially worked well or not worked well, and what we can adjust if there's specific geographic areas that we want to target, if there's, specific communities, specific languages, et cetera, that we're seeing, disproportionate impacts in, and then we can tailor a lot of our approaches to those specific communities.
I'll add just one thing. The in-person events have been a really great opportunity for members to see us and us to see members. We were able to do health risk screenings on perhaps members that hadn't had them done in the year. We're giving away food boxes and bags at those events. So it's really been an opportunity for engagement with the members. And I think we're doing quite a few each week and each month. The one at Stroger last week, I happened to walk through the lobby, which is where they are now, and it was bustling with activity, which is really great.
So are these sites are they ACHN clinics?
Yes.
Do we do some of these in concert with our CBO partners?
Yes.
QHC?
Mm-hmm.
Yep.
So this is just all part of your marketing campaign?
Yes.
All right, and With that, if there's no other questions on redetermination, I'll
I
hand
have
it
a
over to
question.
Dr.
Sorry, Chair, this is Director Robinson.
Good morning, Director Robinson.
Good morning.
Please.
If we can go back to page 22.
Okay.
So here, Aaron, you may mention that the letters go out in May. My question is, who sends out the letter?
The letters come directly from the state.
Excellent. So I think I see a gap, because when the letters go out, and we all know that their records with the address is not necessarily the best, but it is very possible that between county care and other organizations, they have accurate information to contact those members. And those members that the information is inaccurate, the letter doesn't reach them. So now we've missed 45 days. Is there a mechanism that we can get the appropriate addresses that we have, we being county care and the other organizations, to the state, other than the person providing it themselves? Because we know they're not providing it. That's why we are holding this very discussion about the gap existing.
Yes, thank you. That's a great question. And yeah, one of the things that we're really excited about is there's been more flexibility provided around that. So it used to be that without a direct individual calling into, the state and updating their information, there was no mechanism for example, the health plans to provide that information to the state. We've been working with the state really for the past year leading up to this, and one of the things we can do now as an MCO is provide updated contact information that we have. And so we've got processes in place now that both allow us to provide that information, but we also try to gather some of that information from some of these other sources, such as community-based organizations or, pharmacies, for example, tend to have much more accurate information because they're interacting with the members each month as they're getting their scripts. So there is a mechanism now to do that. Certainly, there's still a lot of opportunity within it. And I think the other thing is we know from the state tells us which individuals are going to get a letter each month. So as soon as we know who those individuals are, we start the outreach process to them. And so for some reason, if that letter has gone to a wrong address, we can at least, get in touch with the member, and then we can assist them from there. So even things like at our community outreach events, if an individual lets us know that they're planning to attend, we can pre-print a lot of the information and forms that they have to fill out and have it ready for them at the event, and then help them fill out that information and submit it back. So it's certainly an imperfect process, and I think we're trying to touch every avenue we can, but definitely there's one of the biggest challenges is just the information or the letter going out from the state to the right place initially.
Fantastic. I applaud that effort. That is great. Thank you very much.
Thank you. With that, I'm going to let Dr. Collins speak to our next section around our PBM transition and then some of our other clinical initiatives.
You can go to the next slide. Thank you so much. July 1st, we rolled out with our new PBM. We transitioned from MedImpact to CCH Caremark. We transitioned on a holiday weekend, which there was a lot of concern around, but overall things went well. We had very minimal disruption to our members. Our new PBM continues to do all of the same services that MedImpact provided for us. In addition, there have been no changes to coverage or drugs or process really for our members besides it being a new PBM with an expectation, and we of course will keep this group posted of $25 million annual savings with this transition.
And there's no cost to our patients? No.
Correct. There's no cost for their medication as long as it is either preferred or they have a prior authorization in process. I should make that caveat.
And this switch saved us $25 million?
It's anticipated that it will.
But you'll let us know if that's the case.
Yes.
What were those, what were those qualifiers that drove the decision to change in anticipating the $25 million savings?
That was part of it. We wanted to look at, you know, the streamlining of processes, a larger vendor to potentially provide better response times to us. If you look at CVS, the entity overall, the umbrella of CVS, they're in a lot of our communities where our members are. They do a lot of education around drugs and side effects for those members within those entities. We haven't rolled it out completely, but there's some very direct programming around closing care gaps and the healthcare equity that they do. And so we thought based on those things, potentially, they would be a better partner for us.
So logistics and educational opportunities that they provide in addition to processing claims.
Right, exactly, and the fact that they're in the community already.
Yeah.
You know, if MedImpact was solely a PBM, and that was really all that they did. CVS has a line from MCO to PBM to community engagement to CVS in the community that provides overall in some aspects potentially a better quality for the member around this particular area.
Yeah, will we be monitoring the customer satisfaction or our patient satisfaction?
We
with
actually
this?
already started monitoring that. We monitored it. We have monitored it every day from the time we went live. We do that monthly with all of our vendors, so we
Good.
want to make sure that when we look at SLAs, when we look at response times, when we look at member engagement, we monitor it really closely. And also for our providers and pharmacies also. Other questions on the PBM?
I'm just concerned that hopefully there won't be a lot of complaints about the pharmacy services.
You know, but I don't think it will be because
annually.
the pharmacies didn't change. That didn't change.
Oh, the pharmacy.
Yeah, our network stayed exactly the same.
Okay.
So I don't think it would be any complaints around pharmacies. Sometimes there are complaints around potentially processes and how those things change, but our network didn't change at all.
Okay.
Yeah, it's just that CVS put their PBM up front
Correct.
and say, you know, we're servicing you anyway. Let us manage the whole continuum, because we'll do the education and the equity piece. So this was the added value proposition
We think
for the
so,
business
yes.
from a CVS perspective.
Mhm.
We're serving you already. Why don't you just join our pharmacy business?
And if you think about it, I think the way they touted is that they're separate entities, but we
Sure.
really looked at it as the entire enterprise
Okay.
of what they have to offer.
Yeah, and just to add to that, I think CVS overall has around 50% of the national Medicaid market in terms of providing PBM services. So they, obviously pricing plays into that. They are able to leverage that economy of scale, but also they then have a lot of additional programming that's specific to Medicaid, which is one of the benefits that I think we are excited about, from things like how they monitor drug interactions or do MTM. So there's also, I think, a lot from a quality perspective that we're hoping to benefit from as we move forward. But
So, Dr. Collins, you and your colleagues review the formulary, annually?
I wish. No, we actually get changes to our formulary weekly from the state. So we monitor those changes weekly.
The state makes the determination.
The state makes, so remember, we have as a reminder, we have a single PDL, a state PDL. Whatever is preferred with PA, or non-preferred comes from the state. We can be less restrictive, we can't be more restrictive. And they make changes to that list each and every week.
Wow.
So we make changes weekly in some cadences. We're required to make an official quarterly update to what's on the website, but no, much more than annually.
And it's driven by the state?
Yes.
Okay. And once again, what input would the MCOs have into the
We
formulary?
actually have a lot. So we have a pharmacy committee that meets with IMHIP, which oversees a lot of the MCOs and liaisons with the state. We go to all the state PNC committees. We actually get, not that they take it always, but we give our input as they're making changes related to the formulary. So we do have some input. We as the health plan decided last year, for an example, that there was a drug that's requested often, that's often approved, that covers a wide array of diseases compared to some other drugs in this class. So we wanted to remove PA on that. So we can make that decision as a health plan, and we remove the PA. Although when you talk about the state, it's required PA. So there's some leeway in terms of what you can do. You just can't be overly restrictive or steer to specific drugs.
Has the state of Illinois been involved in any of these expensive drugs?
Oh my gosh, yes.
Where, we hear on TV that it's a $6,000 drug.
Yes. That was one of the issues we had with our PBM last year, that we had to work through, when you think about processing. So there was a drug, I think our encounter form, Aaron, keep me honest, our encounter form only goes up to $999,000. We paid for a drug that was $1 million. So we had to figure out how we pay for that so that our accountants go through to the state. So I think everybody always has the preconceived conception that we don't pay for expensive drugs. But if you look at the amount of spend we have for specialty drugs, it's really high. We have a lot of members on really expensive drugs. And we were just having the conversation last week about 2 new drugs that came out, one for Alzheimer's and one that came out for gene therapy related to hemophilia. Ultimately, we will cover those because we cover whatever is medically necessary that meets our criteria, but those are very expensive drugs. CAR-T, for example, $500,000 for every member that gets it. We cover it every day as long as it meets criteria. So yes, we cover a lot of expensive drugs.
Well, I'm all for it. I have no objections. I just get frustrated when I hear about the appeals that families, you see them on national news, local news, and the drugs are $70,000 a year, $4,000 or $5,000 a month.
Yep, our philosophy has been, we don't want anyone not to have what they need. So as long as we meet the criteria, you get the drug.
Great.
It goes along with being a safety net.
Yep. Other questions on the PBM? Next slide. I wanted to talk a little bit, I'm quite sure you guys hear about it often, but the flexible housing pool, next slide, from our community investment funds. So based on quality measures, the state gives us money back each year that we can use to reinvest in whatever we choose to reinvest in. We pledged $5 million to the flexible housing pool, really to house. It ended up being 67 of our members for 3 years. We did our initial analysis, wanted to look at impact, met with the lived experience advisory board of those folks that are being housed through this project, and focused initially on 2 groups, that is members experiencing homelessness that have severe mental illness or substance use disorder, and families with children. We've since expanded that, but really was pleased to look at the data on the next slide. To date, we've had 54 of our members housed that remain housed. Keiki here and our SU did an initial analysis of the entire flexible housing pool, that is 618 households, 999 individual members. Really looked at the fact of what we see as in housing stability, and also what we see in terms of utilization and cost income. 94% of all folks that have been housed with this program have had a 12-month retention rate, which is fantastic. And then when we look at utilization, not surprising, but nice to see it replicated in this data, decrease in inpatient stays, emergency department visits, in addition to recidivism in the jail. So we'll continue to look at those, but that's the very initial first-year analysis of that flexible housing pool data. On the next slide,
yes. Ask a couple questions here on the flexible housing pool. The individuals, you have 618 households. 990 individuals. How are they selected or determined, or what's the eligibility criteria?
Yep, so these are what are called persistent utilizers of our system. So if you think about our system overall, that's our hospitals.
Say that again.
Persistent utilizers. So those who use our ER, our hospitals, our health plan resources, our jail. So we didn't want to just use look at members or folks or individuals that were high utilizers. We want to look at it across the spectrum. So that was how the initial analysis is done. And then from that initial analysis, we get a list, and then we put our secondary measures on top of that, which were those that were experiencing homelessness that had SUD or severe mental illness or families with children.
Yeah, I know that, Director Story liked the term persistent utilizers. I think in the airlines, they call that frequent flyers.
From across the system, yes, not just in the ER. Yes, absolutely. They would still be considered frequent flyers.
Right. Yeah, my question is, we invested $5 million, and it appears there's some kind of payback to that $5 million based upon the cost savings we get. Have you looked at that?
We are actually in the midst of doing, so this is the whole pool. We're actually in the midst of completing our analysis for our cohort of county care members exactly, so we can see exactly that. We've seen some, it's really early, but some preliminary data around about 25,000 per member savings related to pharmacy, but it's still really early. But yes, we hope to bring that full force.
Aaron, are these the dollars in the aggregate that the MCO saves in terms of, I don't want to use the word profit because you're not profit, but obviously cost savings on an annual basis? Is this part of that, those dollars that you put in this de facto reserve account?
Correct, yeah. I mean, ultimately, those savings would, drop to our bottom line, and then we would allocate that either between reinvestments and new quality or care initiatives or increasing reserves.
Is there a percentage that the state, how does the state make it? Do they annually change the rules based on how profitable, how efficient, I'll put that way, how efficient county care is relative to what they will return back to you in terms, like I use a rebate term?
Yeah, there's what they call a minimum MLR requirement, so a minimum amount of your premium dollars, your revenue that you have to spend on medical care each year, and so that's 88% of the total premium has to be spent on, either the cost of care members, so the claims you're getting from providers, or quality initiatives also count towards that 88%. And so then obviously you have administrative costs on top of that. So that 88% serves as a limitation on how much efficiency you can have.
And on an annualized basis, it's more efficient. You, county care becomes to keep more. Over the last 2-3 years, the state rebated in terms of more dollars.
Yeah, so there's, we typically run our administrative cost somewhere between 5 and 6%, to give you a sense. And then our medical costs have been ranging between 89 to 93% given on the year. And obviously there's a lot of variability. We had the pandemic, and so there's, sort of whatever's kind of left over in that given year has been what we've been able to dedicate back towards reserves. Again, we've made a lot of changes in terms of incentive programs or different things that we're investing in for quality, telehealth access, behavioral health's been a big focus this year, for example. So that's sort of the framework that we think about some of those decisions in. And for the flexible housing pool specifically, I think, Director Harrington, to your question, is we've made this investment a few years ago. And so, one of the questions I have as we're going through this evaluation is that sustainable? Should we be continuing to reinvest in that? Like, what does that look like? And there's a spectrum of housing too. This is sort of at the far end of permanent supportive housing, but there's also a lot of opportunities for temporary support or for other partnerships that we have that we can house individuals potentially that maybe aren't as high acuity, but still have a need, and it's kind of matching that ability to invest on that housing spectrum with the acuity needs and where the members are.
And when you make an investment, you expect a return on the investment. And ours might be money, but more importantly, I think the real thing we're trying to do is make sure that the population we serve continues to be healthy and utilize healthcare when they need it.
Mhm. I was gonna bring up sustainability at the end of the next slide, but yes, that's the conversation we continue to figure out how we have with the state. I don't think it's sustainable at each health plan level, which is why we are really, advocating for it to be a covered benefit under Medicaid, you know, just as we cover drugs.
And we may have the data
Cover
to
it.
show that there's a
Mhm.
benefit to do that
Right,
in terms
exactly.
of reducing
That's why we're
costs.
starting to have a lot of these conversations on different levels. Other questions? The next slide just graphically depicts what I just said. So if we look at this, this goes from 2018.
I just think this is such a great slide here,
Yeah,
because I would rather see reinvestment, to my colleague, comment, in terms of reinvesting in people as opposed to paying out dividends to stockholders.
and we agree, which is why we've done it and why we continue to do it as one of the few MCOs. It really is a no-brainer. When we talk about improvement of quality of life and quality of health, and social determinants or risk factors, you cannot not talk about housing. And I think the data, we've seen it when we started the process, seen it a lot for California and New York. That's why I say I was glad that we could reproduce it within Chicago and within this population.
Great work all the way around.
So are you gonna write a journal article on this?
We actually submitted one. It was denied. We continue to do that though, yes. We continue, and we're talking about it in every venue because we think it's gonna be really important for others to, sort of jump on the bandwagon and invest. This is an opportunity really beyond healthcare, but for developers to get in the game of healthcare. So yes, but to your question, we did submit it. It wasn't accepted, but we'll continue as we do analysis to submit.
Chair, may I ask a question?
Yes, please.
Dr. Collins, your,
Yes, sir.
your county care utilization and cost outcomes, are you able to put dollars to those percentages?
We're working through that now. That's our goal, yes. We have started to look at it on the scale of pre-housing and post-housing, how much utilization was there in the hospital, in the ER, and for drugs. And we're using that as the context of the post-evaluation. So our goal is to, yes, be able to put a dollar amount on it.
I would find it interesting, and I'm not sure what the mathematical tricks would be utilized to get that 22% dealing with the jail registration, because I just can imagine not only the cost of actually incarcerating a person, but if these individuals are able to become productive citizens as a result of having stable housing, now how does that really impact the economy of the county, as well as the impact on individuals who may be victims of some of their actions?
Thank you for that, Director Robinson. We, and maybe we can bring that at a future session, because we are getting that population also within the health plan. That's part of looking at the analysis of, can we, with wraparound services, that is within the health plan, interaction and intersection of healthcare and housing, can we change recidivism rates for that population? So I'm hoping we can have some data on that and be able to present that before this group. But yes, absolutely, totally agree. That's worth every dollar.
The reason why I asked the question, because when we start to talk about this being sustainable, those dollars may all of a sudden make that become a sustainable practice because of what we're saving.
Right, absolutely. That's our thought. We just have to continue to prove it, and the state has to believe it. We can go to the next slide because I talked through this one already. The other area we wanted to talk about was our program around domestic violence. Actually, can you go one slide forward and then we'll come back to this slide? Yeah. So we looked at our initial data before we got started. We looked at last year based on the questions we currently have in our health risk screening to see what was the impact, what do we know about our population now, and found about 822 distinct members that responded yes to some of our screening questions. which then led us to say there's probably some more work that we need to do around domestic violence. So we can go back to the previous slide. So we started some work around training. We trained up at least as of from between March and yesterday, actually, we've trained over 250 of our care management staff on what is domestic violence, how to recognize it even without any marks, how to get our members to safety should they need to be gotten to safety, and how you intervene without putting yourself at increased harm when there's violent situations that you may enter when you're visiting our members in the field. The next part of that, we looked at our questions in conjunction with some experts in the area to look at where we asking the questions the correct way, and identify some questions that we needed to tweak, and we're working through the tweaking and getting those updated within our system. And then the next phase is really looking at what a program looks like. In a meeting recently, we decided that really we want to look at what our referral process is, how we get both those inside of our facilities and outside of our facilities, the help that they need around domestic violence, how we begin to house them, whether it's emergently out of an emergency situation and then permanently, how we provide advocacy and then workforce development for that group. So working through those last portions now. And of course, it always goes back to how do we fund housing, how do we fund programs, so having some conversations about that. But really early, some really nice work, at least around training and beginning to identify. Once we identify, we want to be able to provide some instruction to our staff on what they need to do. So working on that, just wanted to give you guys a highlight of that. And I think that is my last slide before Alex comes. Any questions?
Is there anything that we as Board of Directors members can do to enhance the, this particular slide, number 36, addressing domestic violence? I know that these are in progress, in the queue. Is there,
Absolutely.
how can we be supportive of this in terms of either funding, advocacy?
Exactly that. We're working through sort of a one-page education description of what our program is, how folks get resources, and then ensuring that our board takes that out to everybody. You know, ensuring that any avenues that you guys are in, you have everybody understand the programming that we have so that we can intersect, because we never really know where it happens. It happens all over, and very commonly, there's nowhere for them to go because of the shame and the stigma that's associated with it. Our hope is that once we have that one page, all of our commissioners are getting them into their newsletters, and we're actually using the resource. So I would definitely say advocacy, and probably at some point, once we figure out the portions of housing and support, there'll have to be some discussion probably around what the funding looks like for that outside of the flexible housing pool.
Well, I would welcome the opportunity, Dr. Collins, Aaron, to participate, you know, as a board member and in this endeavor, and just try to help connect the dots. And even in the other hat that I wear as the Deputy Chief of Staff for Cook County, to try to connect the dots there in the Office of the President and other areas of our county government where we can link. And once again, you know, this enterprise thinking, this is an opportunity around something that's a sad commentary on life, but we understand that this is the reality that you all have identified. And if we as individuals, you know, and as a body can coalesce around this particular objective, you know, I stand ready to do that in terms of enterprise thinking, you know, so we can really work with different other separate elected bodies within Cook County to try to accelerate this great work that you all are doing, that you all have initiated.
Thank you.
And will do. I know that. I believe it.
I'll be in touch. Thank you. Other questions?
Thank you. Thank you.
Good morning, Alex.
Good morning, Alex. How you doing?
Good morning. Good, thank you. How are you?
Doing well.
Great. Interim Chief Communications and Marketing Officer, here to share with you the results from our Choice 2022-2023 County Care campaign. This is a campaign that we do every year, starting in the late fall, ramping up to about the first quarter. That's when we have a critical mass of Medicaid members who are in their choice period. So we want to make sure that the health plan has good visibility in the market as people are selecting which plan they'd like to be covered by. So the campaign for 2022-23 represents a $1.5 million investment. We had 275 million total impressions, which is over a 53% increase from last year's campaign. So you'll see we had a 15% increase in our spend, but over a 53% increase in our impressions. So we're getting increasingly sophisticated in how we're reaching our members and giving them messages that resonate with them. We also had 244,000 clicks on our digital and streaming ads, and resulted in 15,000 total calls to the County Care call center. Importantly, during this choice period while we were in market, we had 12,000 new choice members, and that's a 23% increase from the campaign time last year. Next slide, please. So this is an example of our out-of-home and transit creative. We had a significant proportion of an increase in our impressions from out-of-home and transit, just as more people were out and about in a para- and post-COVID world. They were riding transit, seeing billboards. So you can see the creative assets there, but we saw a good ROI from out-of-home in the last campaign period. The next slide shows broadcast, streaming, and cable. We had multiple spots running on broadcast TV, local cable stations, and streaming TV services. We earned 12.6 million impressions on these services, and nearly 3,000 clicks for people who are streaming on a tablet or phone or laptop.
The pie chart, I guess it's color coded. The 30%, since I'm having trouble with the colors, what accounted for 30%? Is that the order in which they're listed, or?
Yeah, that was the Canela. That's a Spanish language streaming service, and that's proven very successful for us. We've been advertising with them for a few years now.
And you said, but that's a bilingual service?
It is. So and we had Spanish language creative as well. So it ran on Canela and Univision and Telemundo.
And that's reflective of our patient population?
Absolutely. The next slide shows digital. We had over 36 million total impressions on digital, and I'm really excited about the advancements that we continue to make in this space. This is more than a 50% increase in our impressions from last year. On Google, we had a 22% click-through rate. That is unprecedented in the industry. Mostly you're seeing click-through rates of 1 or 2%. So this means that we're getting in front of the people that we want to be getting in front of. We also had, through Google, a 33% increase in calls to our call center. On Meta, which includes Facebook and Instagram, our click-through rate was 26% higher than the healthcare industry average. And again, with each campaign, we're really better able to fine-tune how we target people with messages that are relevant. And we're, on social media in particular, we've been able to be more economical and effective. Our spend on social actually decreased by 47% with Facebook and Instagram, but our click-through rate increased by 32%.
Do we track in-kind media that we don't pay for that puts us in a good light, or do we collect that?
So we do have bonus impressions, and I believe on broadcast and streaming and out-of-home that's noted out specifically on how many units we paid for and how many were bonus spots. So just a few other comments relative to our campaign. We target the entirety of Cook County, but we do have some priority zip codes, about 25 of them, and they really range from north and northwest suburbs to the city and then into the south suburbs, where we see a lot of opportunity. We have some membership, but we see potential to grow more. And then a few of those priority zips are also around areas where we've expanded our network in the last year or two to let people know that there are covered providers right here in your neighborhood. We are preparing for our 2023-2024 campaign, and we're going to be adding about a dozen additional opportunity zip codes to really heavily target in that campaign. For this upcoming year, we've got creative going to focus groups next week. We're really excited about the assets that we've got going forward. And so we'll be in market again later this fall for the 23-24 period. We're increasing our spend for that campaign from 1.5 million to 2 million. We're seeing really great ROI with our campaign, and then with the ambiguity around redetermination, we want to make sure that county care is really highly visible.
What is the criteria for making a specific area a priority area?
Yeah, so we looked, and I can get more specifics, but essentially we looked at areas where we have membership and network coverage, but maybe like 1,000 members, where other plans have higher proportion of members. And we say, we've got network coverage, it makes sense for someone to want to be covered by us, and we know some people are. So those are the zip codes where we said, I think we can get better market penetration in those zips. So that's why we've chosen to target them. And then again, with our network expansion with Loyola and North Shore, making sure that folks knew that in those areas, those large providers and their doctors are now in network.
Alex, would it be a fair assumption or somewhat that the 25 zip codes are synonymous with the SDI, then Cook County, those communities that we identify as very vulnerable, that the Department of Public Health, yes, that the department, during COVID, we identified those SBI, Department of Public Health, and CDC, they use the same criteria, et cetera. So, would you say this is an overlap?
There's definitely some overlap, yeah. So there are communities and zip codes that we're very familiar with.
Oh, wouldn't they not be the same?
Not all the same. In some of the social vulnerability index communities that ranked really high in COVID, we've got really good market penetration, but certainly there's zip codes that are in or the same or adjacent to.
Yeah, to add to that, there's sort of two goals we think about with every campaign. One being, how do we continue to sort of retain and continue to reach the core of our plan, which is, obviously very heavily in the social vulnerability areas. And then the second phase is, how do we think about new growth into the plan and new market penetration, which, to Alex's point, in the past year or so, we've started to think a little bit more about penetrating the suburban areas where we've had less of I think, an overall market share than some of the other plans. And so we've added some additional providers to our network in those areas, and then tried to layer on some of our marketing focus into a couple of those zip codes as well. So there's sort of two main goals as we think about each marketing cycle around those core areas, west and south, which have obviously the sheer highest number of individuals on Medicaid, and also by far the highest density in our plan. And then how are we thinking about expanding into some new, to try to gain new members?
I guess, once again, it goes back to the conversation that we just had with Dr. Collins about enterprise thinking relative to SBI, Department of Public Health, and the work that you're doing to support county care in this endeavor. I hope that this is, once again, another opportunity for the cross-fertilization of ideas and operational initiatives in Cook County in terms of the target market, SCI, what the Department of Public Health is doing in their work. So I offer that as not a question, but as just as a comment.
Yeah, absolutely. It's a point well taken.
Any other questions?
Alex,
Yes.
do you have a click-through by age?
I don't have that breakdown in front of me, and I'd have to check back and see if we get that granular in our reporting. I can tell you that when we've been expanding our spend on Instagram and TikTok and been seeing really good engagement there. So I feel like we're creating more content that's relevant to youthful audiences, and want to make sure that we're capturing them early on. But I'll look in to see if we can get that granular.
I'm just curious because as you mentioned, your numbers are outrageously great. They're good. I mean, beyond good. They're fantastic. And when we look at the idea of said TikTok, surprisingly, I have found that it does skew the ages. I have daughters that look at TikTok, and I have a mother-in-law who looks at it. So it spanned the ages. I'm not one of the fans, but apparently I don't count.
We'll get you another way, don't worry.
Okay, thank you.
What is the period of time that you concentrate? Is this all year round, Alex, or is it?
Yeah, so we know that a lot of Medicaid members have a choice period in December and January.
Right.
So we try to get in market in September, October. We were a little late this year because we redid our marketing contract, so we were pushed back a few weeks. And then so we're in the market in late fall, and then we go through until later in Q1 to make sure that we're catching any folks who might be kind of in their grace period for choice, and catching folks who did not choose, were auto-enrolled, and they've also got a period there where they say, oh, I was auto-enrolled, but actually I would like the opportunity to choose, so they have that time. So we want to make sure that we're still catching that kind of tail end of the group as well. We're planning for the same time frame for our upcoming campaign. What happens with redetermination over the next 10 months may change that in the future, but our goal is to be in market with regularity, at least with the same time frame that we have been in the past, if not expand that further in the next year.
So you just do a little lead time prior to open enrollment, and you lag time into the first quarter of the calendar year,
Mm-hmm.
to run that campaign. Are there, with respect to the digital and the broadcasting and the transit, et cetera, are there other activities in terms of boots on the ground activities or engagements with other CBOs, et cetera, beyond just the technology component?
Yeah, absolutely. So whenever we do a campaign, we push out our assets to our CBO network, and then we also share them with county commissioners for additional sharing. We have a really robust community outreach team. It's something that Aaron and I met on yesterday too, on opportunities to continue to expand it. And so they're present at a number of events and are always representing county care and making sure that they can be that interface for folks, showing that we're in their communities, and then answering questions or connecting them with services that they need help with, paperwork or choice or redetermination.
So these are staff that work in the community year-round?
Correct. There's staff, and then I think there's some additional.
Yeah, we have 2 vendors who support with manpower, essentially, to help represent county care to make sure that we can be as many places as possible in one time.
So is that a contract that comes up for annual review to the board?
I believe so. So I think they just went through last year. And I'll check again. I think their timing might be coming up again soon.
Okay, so that's a contract that we will be seeing in terms of review and approval?
Yes.
So that's something, because we're right on the cusp of the fall open enrollment period. Right?
Yeah, and we have, I don't recall the number, was it 60 events in August that we're staffing? So it's a good number across the county. So having those extra hands is really helpful.
Yeah, and that's what that's my question, Alex. Where's the additional manpower coming from? Because we have the routine community engagement team, I would imagine, and then doing this open enrollment, this bolus injection of man hours that you would need to support to stand up during this choice period. I was wondering, where's that?
Yeah, it's actually interesting. We see a really steep decline in community events in the winter. So in the summer, we have a lot, primarily in the summer, we have a lot more community events to staff. So as we kind of wind down with the volume of community events, we're ramping up with our paid media So obviously in the winter, we have the ability to staff almost every event we get a request to participate in. It just, the volume isn't there. You know, it's hard to get people out in winter, and then we've passed a lot of the back to school and other, you know, festivals or community big.
Oh, I agree, it makes sense, that, you know, but, my reference point was just at the beginning of open enrollment, boots on the ground, you know, 'cause I experienced the campaign, you know, people knocking on my door.
That we have not delved into door knocking yet, but if we can talk about the staff that would be required for such an endeavor.
Well, we know it's effective.
Sure thing, and we keep getting better. Thank you.
Thank you. Any other questions from the board members? Thank you, Alex. Aaron, is there any additional business to bring before the board?
No, that concludes our presentation.
Thank you very much, Aaron, and the rest of the county team for your presentation today. No other action being brought before the committee. There's one action item, the minutes from 4/21/23. To any comments, be accepted and approved. Hearing none, I would declare the meeting adjourned. Thank you. Thank you all.